With me is Lorna Smith Benjamin. She is a researcher and psychotherapist, developer of Interpersonal Reconstructive Therapy, a treatment for personality disorders that draws heavily on attachment theory. She is guided by this desire for clarity in psychotherapy theory, practice, and training, and I hope we get a chance to go a little bit through some of the main contributions you've given us to the field. So thanks so much for having us.
Thank you for inviting me. It's a pleasure to talk with you.
So, looking back on your career, you once wrote, "I love to work with seriously troubled people who are driving everyone else crazy and have been unresponsive to many previous treatments." So I can't resist to start off by asking you, what do you think drew you to this interest of working with the really hard people?
A childhood fantasy of a city girl living in suburbia would be to have a horse. And when I was a teenager, my parents, who grew up on farms in 𝗵𝗲𝗅𝗍, New York, but my father was an executive, decided they needed to go back to the farm. And so they bought a farm and we lived there. My father commuted to work in Rochester, but I had a horse, and the horse was a very difficult horse. But we became good friends. And I just learned, I've always loved animals, and one of my daughters is a veterinarian, so I guess it's genetic, but I just enjoyed developing the relationship with that horse, and she was just wonderful. And after not too long.
You enjoyed developing a relationship with a tough case.
That's right. You know the story, The Horse Whisperer. That has a lot in common with what I do. And it started with a horse.
I know you were also into music, and you practice music, and the discipline part of that also helped, right?
Oh my, yes. Oh yeah. The idea that you can pick up an instrument and then show up in Carnegie Hall in 3 months is just not going to work. And so, yes, I studied at 2 conservatories and learned self-discipline. It's a good thing.
And to train for 3 months in psychotherapy also won't get you to Carnegie Hall.
Not at all. It takes a lot of hard work and self-discipline and understanding of basic underlying theory.
Yeah.
That all of those disciplines require understanding underlying mechanisms in theory. It's just a given.
Actually, now that we're talking about this, I'm going to go a little bit off track because I'm curious to ask you about your feelings about our system of education in terms of psychotherapy training. Because it has changed a lot over the decades.
Oh my!
So, what are your feelings towards it nowadays? I know that you've retired from Utah University, correct?
Well, you have to put that in quotes. I'm down to 60 hours a week.
Well, that's very, very much quotes.
Yes, I'm fully retired from the Department of Psychology, but I still work as an adjunct professor of psychiatry at the University Neuropsychiatric Institute. Mm-hmm. And just 1 day a week there, I see these cases or teach a little bit, the residents or psychologists or social workers.
Mm-hmm, mm-hmm, mm-hmm. And from the time you started your own training and from the training today, what do you think have been the main victories and defeats?
Well, I have 2 histories. One in a medical center, that was at Wisconsin, and that was my early training. I had 4 years of postdoctoral training and then went all the way up to full professor, learning and teaching psychotherapy. And then I came to academia, which is a whole other world. Mm-hmm. But to be brief, I, of course, started out with psychoanalysis, and I still value it deeply. There's tremendous wisdom there. It's object relations psychoanalysis. It's a large part of what I do, although I admit I do it in, I think, a more disciplined and organized way. Mm-hmm. But that's, the idea of the relevance of childhood, the idea of there is an unconscious, which is being rediscovered now. It's got new names like the hidden brain or the fast and slow brain. Mm-hmm. I call it, along with the researchers who've been doing work with it all along, the subcortical and the cortical brain.
Mm-hmm. Mm-hmm.
And, you know, the unconscious exists. It's nice it's being rediscovered.
Well, you talked there about your work being a little bit more structured, and that's actually something I also feel, and I've already spoken a little bit about this need for clarity that I think you always had, and even I remember you writing about need for clarity when you were teaching your own students or supervising. So I'll be curious to ask you, how do you think this straightforward attitude, this clarity, also plays in the clinical setting? Let me put it another way. I was wondering how you perceive to be the role or the importance of clarity and unambiguous communication towards tough clients.
It's vital. Of course, it depends what you're clear about, but if you're, first of all, empathic and hearing and listening to and honoring what the patient says, you have basically valid material. If you make it interactive, which is a characteristic of all of the basic sciences, I call them the real sciences. Mm-hmm. In other words, trait needs to be contextualized. I don't think we are little trait machines walking around getting our needs met and imposing our will on others. I think instead we're evolved creatures that respond to context, and everything is in terms of how to be safe and what to be afraid of. So everything has to be interactional. So that causes me, when I'm interviewing patients, to ask questions like, what might you be depressed about? Or what do you think makes you anxious? And, you know, when they go into their broken brain or whatever, I say, yes, that could be the mechanism, but in terms of how you see the world, when do you get depressed? And that way I make it interactional. Mm-hmm. And so the detail of that in the patient's own words, detailed descriptions of what he said and she said, mm-hmm. and I said and I felt, all of that gives you what I try to encourage students to do is develop pictures. If you're writing a script for TV, you have all of what's going on and what people are saying and doing and convey what they're feeling. That kind of specificity and clarity is going to be relevant to the symptoms and why they're here now. So interactional, detailed, he said, she said, that's a love of raw data, not the patient is defensive. I don't know what that means. Mm-hmm, mm-hmm. But if I say the patient talks a lot, so nothing else get a chance to happen, okay, and I can check that out by reflecting, you're talking a lot, how are you feeling about our process? That's a string of free associations to your question. Mm-hmm. I hope I touched some on it.
You did, yeah. It feels like you value co-constructing the therapy with the client.
Yes,
yeah.
Yes, absolutely. Everything in IRT begins with assessing what I call the input, or what's going on in your world, and then the response, what are you doing, and how does it affect your self-concept? That's one of the basic little algorithms, I call them.
Mm-hmm. Well, speaking of algorithms, of course, we have to talk about the model you develop also, the structural analysis of social behavior. Mm-hmm. And it's very helpful, at least for me, to conceptualize interpersonal and intrapsychic behavior. It pulls a lot of stuff together. There are a lot of resources online for people to check it out more, but I would still like to challenge you to try to briefly give us like an overview of that, and maybe what you think most excites you in terms of the research you've done along the years.
Oh. Well, TASB's the secret, the Rosetta Stone to everything that I do, because it evolved first when I was Harry Harlow student in the primate lab at the University of Wisconsin. I learned to observe and not project onto the subject, and to make everything interactional. And, you know, working with monkeys, you understand that we're, as I say, surviving creatures. So I got in touch with primitive basics that I call sexuality, power, aggression, and territory. And those are the basic poles of the SASB model, and they define the underlying dimensions. And I knew that you have to think about that when you're working with people too. It sits there all the time. I don't think of sexuality and aggression as given energies that have to be unloaded or placed somewhere. Because if they don't go here, then they go there. I don't believe that. I think they are adaptive affects and are associated with specific behaviors that also are adaptive. And so I know that hostility is present in all of us, and nature gave it to us for a purpose. And thinking as a biologist, I think, well, aggression has a purpose. What is it? It's to get control or cause distance. That's how it helps us. So it's not a basic energy that we got to unload. It's a function.
Yeah.
So I do a functional analysis of affects. And the SASB builds on those basics to describe everything in terms of combinations of those underlying basics. So, for example, when I respond to your question, one of the basic dimensions is that we're both being friendly. We're not hostile to each other. And so that's a certain amount of friendliness. And when I speak about my own view, I'm expressing autonomy. That's a version of psychological territory. So the combination of moderate amounts of friendliness and moderate amounts of autonomy codes out on the SASB as disclose. Okay? And that can be rated. You know, when you use the SASB, you don't just look at a video where the person interacting and say, oh, this category fits best. I think that person right now is walling off. Instead, the SASB coders learn to identify who's interacting, make it interactive, and then identify whether it's friendly or hostile, and then identify whether it's separate or interdependent. And then depending on 3 dimensions of focus, whether it's about another person or whether it's about the self, you're a European, so you will understand the word transitive and intransitive. I have to be careful here in America. We just don't. So, but anyway, transitive actions are prototypically characteristic of parents and initiation, and intransitive reactions are where most of the psychiatric affects come that accompany those behaviors. So if you're submissive, you're kind of helpless and depressed. And so everything is made up of those basics, and you learn to strip everything down into those, and I sort of just feel them. But it's a discipline.
Yeah.
It's like, you know, when you're playing music, you could name the chord structure, you could name the principle, but you also sense it. And so you get the lower brain in tune with those, and your perception is very, very accurate. So now, when I talk to patients, right away, I connect with them at that deeper level. And they calm down, as the wise therapists of the 60s knew. When you get matched with where the patient is, it's calm. It's calming. I had the good fortune of having Carl Rogers as a supervisor for 6 months, and he practiced what he preached, and he would just track along. It's a good thing.
Actually, I'd like to ask you about your teachers a little bit later, but staying also with what you're saying, actually, this coding that you do, and I imagine for you now, it can be quite fast. You can look at the behavior and kind of maybe see a little where the person is. I'd like to try to connect this with the stages, if you could call them, or your clinical decision making. Could you tell us a little bit about how can you apply these categories that you spoke of the SASB with everyday psychotherapy, with how you decide to be or what you decide to do?
Oh, you may be talking about the predictive principles that come with the SASB. Maybe I should now take a little bit of time to show you my screen and make this concrete.
Please.
Before I do that, why don't we pick an example? Let's see. You want to give me an example of a clinical event?
Yeah, sure. How about a boy that after you propose, you do a role play? he says that he doesn't want to, and he blacks off for 10 minutes. Just doesn't talk.
Okay. Now, if I was doing a consult with you,
Uh-huh.
I would right away ask you to become that boy,
Uh-huh.
and I would interview you and do a little role play, and we would discover that that's a very deep story, that that little boy is embedded in your unconscious, and you're quite capable of becoming him. And when I do demonstrations and workshops, that's my favorite part,
Yeah.
where I ask a therapist to be his worst nightmare, and then or hers, and then we talk a little bit about it, and then we do a therapy session. Okay, so I'm sorry I interrupted you.
Yeah, I just want, now that you say that, I read also that you had done that, and I was always curious. Do you think this is also interesting or effective because the therapists themselves can find it in themselves, what they are seeing in front of the other person, and so they can attune better to the other person?
Absolutely.
That's
They know it. They haven't been taught to pay attention to it,
okay.
at least here in America. I call that respect for the unconscious, but they're just wonderful. They'll afterwards they'll say, well, I never asked him that question, but I think I know what he would have said.
Okay.
But the relevance here is that when the boy is quiet, the first thing I will do is ask him how he feels about our interview. That would be going to the problem of collaboration. And I would find out that he was perhaps frightened of what I would write and what would happen to him, or he would think I was his mother and going to play can opener with him. But I would have to right away, the analyst might say, explore the transference. So it's hard for me to code. I can code what I would be doing when I do that.
Yeah.
And so do you want me to do that?
Whatever you feel right. Actually, you've touched on another thing that I find interesting, which is how it could apply to the therapists themselves, because it does seem like the model could also help a lot to shed some light on even countertransference phenomena.
Oh, yes. Well, I think of the SASB as the lens, and it can be used to describe the patient's interaction with the therapist. It can be used to describe the therapist's interaction with the patient, the content of the patient's speech, which is distinct from the process.
Yeah.
So that's a guide in teaching and also practicing. I have to track all the time the patient's story, that's the content, and my process, the patient's process. Those two tracks are going on all the time.
Yeah. Yeah. Yeah.
And they will converge sometimes and diverge many times. But the patient's content will be the basis of his case formulation, and the process will probably reflect the consequences of it. The SASB has helped me there by the research results over half a century of research. Some mine and a number of other enlightened people, many of them from Europe, I should add. Here in America, SASB is not terribly popular. It's because it's had some dedicated enemies under the heading of the single circumplex, and it's also a bit complex.
Yeah.
And so, but it does sharpen the perception, clarify the detail, and organize it. So I'll give an example as I just threatened to. Well, the dimensions of the SASB, which, by the way, has parallel models for affect and cognition. I think they all come as a unit. We have a perception, and that triggers automatically a feeling if the issue is about threat or safety in the primitive brain. And that automatically is linked with behaviors of a specific sort that facilitate adaptation. Okay, so there's affect that goes with behavior, that goes with cognition, particularly the unconscious perception called, it has different names. That's another word, perception. I want to say the name of, it'll come to me, of the wonderful developmental psychologist who dreamed up that word. I call it primitive brain. Anyway, so the first thing you do is, here I'm coding myself with you. I'm going to make you the boy. Quiet. And so I am have one kind of focus. If I'm going to try to talk to you, I'm going to focus on you. So I'm engaged in transitive behavior. And that sends me down one of 3 tracks. And so on that track, the next question is, am I going to be friendly or hostile? And I'm going to be friendly, about midway there. Of course, if you're not, I do get angry with patients sometimes and hostile, but it's rare and it has a particular purpose. Have to know them, have to have a good relationship. I get in trouble if I don't wait until then.
But it can be of value sometimes.
Yes, yes, because it's for distance or control. And if the patient is just getting way out of control, I'll do a power struggle for the control of the interview. Okay, so the next thing is the interdependence. We chose here this first one. And so that means that when we come down to the vertical part, we will look at the first of 3, the transitive group. So we know we're friendly, and as I'm looking at you, the boy, I'm going to give him his space because he obviously wants it. So I'm going to match him in autonomy. So now we know that I'm going to be on the friendly side of the street, and I'm going to be on the separate side of the street, which will put me in this quadrant of friendly differentiation. Right there is a difference with the interpersonal circle. They don't have a place except for withdraw as kind of a little section all by itself. The space is of friendly autonomy, and that is a very healthy place to be. It's very important in defining therapy goal. Very many patients lack that. They think either you're in control or you're submissive.
Yeah.
And that would be to live down here in enmeshed space.
Yeah.
So we know then that it's going to be friendly autonomy, and right there is where I was. So I'm going to affirm him. And if I do, perhaps he will disclose. Now, that's the therapy, of course, being a devotee of detail. The SASB model can go into practically infinite amounts of detail. That particular part of space, including just varying amounts on these 2 axes, will allow you to go from very warm, uncontrolling, or an unseparate sharing of space up to complete freedom. And with a boy, I will probably be listening and in a friendly way and trying to show understanding.
Yeah.
Now, I'm not going to confirm he's okay as he is in general, but I certainly am affirming his right to be silent if he wants to when I start there. And then there's the principle of complementarity, which says what will happen if you do one thing, what was the other person going to do? And complementarity was first started as an idea that I think I recognize anyway by Bob Carson, who talked about it with a version of the single circumplex. And it's just what matches what, naturally. I think I've got plenty of data to show it's valid. And I think it's like, it's a given that if one person has one position, there is a natural draw to the complementary position, like positive and negative charges in physics. So if one person affirms, the other one's more likely to disclose.
Yeah.
If one person protects, the other is more likely to trust. And if one person blames, the other is more likely to sulk.
It's very interesting because even though the model itself is completely dialectic, there is a cause-effect logic here also.
Oh, absolutely. That takes me to the natural biology, but then I'm spinning down yet another trip.
Exactly.
And so, but yes, I think I read the other day that, I went to APA presentation by one of the DSM factor analytic personality theorist who was saying that the factors they're proposing might be a periodic table of the elements. And I thought, right. I think, I do think, I have said, I have tried to do that with SASB, but not by sort of factorial analyzing and making and naming it, but rather by building from the ground up, by using this basic logic here.
Yeah.
And saying, well, if we have something that's moderately friendly and transitive and giving of autonomy, what might that be?
Yeah.
And so I created these words. I actually started with this version, if anybody cares to know, and just worked with language until it fit the underlying dimensionality, which I've checked with having naive raters rate them, of course. And it works. It reconstructs it very well. If people rate the items describing these points, if people use the items to describe themselves, then factor analysis will yield not a circular shape or a triangular shape, I mean a square tilted on its edges, but an oval. And that's supposed to be a fatal flaw, but I think it just simply means that when you're applying this to people, the attachment axis carries more variance than the interdependence axis.
Yeah.
So there's a distinction between whether you're rating and assessing the items or whether you're using the items to assess individuals. And the results differ, as well they might. Okay, coming back to this poor lonesome boy here, you were hinting at the principles, the predictive principles, and complementarity is one. And the model spells those out. The opposite of affirming is to blame. And every one of these points have opposites. And the language works, and the ratings work, the dimensional ratings work. And we also have the principle of antithesis. So if this boy is, he is, if we code him, not me, he is walling off.
Yeah.
That's the quadrant of separate hostility. And he is drawing for me to just ignore him. Say, okay, I'll go on to the next case. But the antithesis is to do the complement of the opposite, or friendly nurturance, which I will go to, but not at the beginning. You don't try to get control of the horse when it's frightened, okay? You have to connect first. And so, but it will be important to, if we're going to go anywhere with this, to be able to move from the empathy down to some kind of asking of questions and some kind of leading him to a new place.
Yeah.
Okay, so I'm covering a whole lot of ground here. Do you think it's too fast?
No, I think it's good. Actually, now, of course, it directly connects to me with a process outcome research question, which is kind of what I think you're saying, is that if we can be responsive to these categories, then probably the outcome would be better, correct? Maybe not so simple.
Well, that's the problem.
Yeah.
I could, when you work with these very difficult cases that I do, they are hanging on for dear life to their version of how to be safe.
Yeah.
And it's somewhat of a challenge to get them to come along with you.
Yeah.
I usually do manage to do that. So yes, and the SASB is really the lens.
Yeah.
And it clarifies what's going on, and it does reflect these principles, but I don't think now I'm going to shift to complementarity. That comes intuitively, but it's like in music, the discipline is still there.
Yeah.
And so I'm more likely, if you want to know what the conscious process is, to use the IRT model, which is a direct spin-off from what I've learned using SASB. IRT is relatively recent, but just to quickly hit the highlight that's relevant to your question here, The IRT model describes principles that link what you're seeing now to the childhood, which of course is profoundly psychoanalytic. And does it through 3 copy processes, which I call identification. That's an analytic idea. It's be like him or her. So if the patient is getting in fights all the time, and you learn that so did his dad, he's identified with his dad. I mean, it's not rocket science. It's a copy process. And so identification is one way we are shaped, not just in behavior, which is what SASB itself does, but in our affects and in the behaviors and in the perceptions that trigger those affects. So if, for example, Dad had, a meltdown, if people didn't do what he said, the son learns that if he's identifying with father, that he should be dominant and people should submit to him. And he will get angry like Dad did if they're not submitting. That's anger for control. We can see that in some political figures right now. And so there's the identification. Then there's recapitulation, which is to repeat in adulthood the very patterns, affects, perceptions that you did as a child. So if you were kind of browbeaten and abused and you're female, you're very likely to recapitulate that and find a controlling, abusive person. That's an old story. So it's a copy process of recapitulation. And then there's interjection, which is treat yourself like you were treated. Harry Stack Sullivan first talked about that. It's the principle of the SASB model. If you have someone who is always blaming you, you're very likely to doubt and put yourself down. So I'm aware of those predictive principles and those copy processes. And when I'm doing an assessment interview in terms of IRT, I'm trying to do the dance with the patient, starting up here where they are, and helping them realize that their self-sabotaging behaviors, which are accompanied logically by their symptoms of depression or anxiety or anger, if they're negative affects, are totally understandable in light of their training with their attachment figures. And the natural biology that I've been emphasizing lately that accompanies SASB and IRT says that's because the human is a complex creature and is very highly adaptable. And there's no way all of that could be pre-programmed. So what is pre-programmed is the proclivity to copy what the people who've survived already, namely the prior generation, are feeling, thinking, and doing. So if you grow up in a family that's frightened of people of another skin color, you're going to be frightened of people of another skin color. And you're going to do just what the parents did to be safe, which is avoid them or whatever, attack them. And it's automatic, and it's intended by nature to facilitate adaptation. Obviously, it can go in maladaptive directions. That's an example. Racism is an example. Sexism is another example. So the copy processes are what I go after. I'm using SASB as the lens, the language. It'd be like I'm playing a piece, and the SASB is kind of the theory of music. You have to know the underlying structure. And so too is the natural biology. It's about the mechanisms. And so they all fit together. The lens, the copy process links. I have another concept that is called gift of love, which is explaining the link between the attachment figure and the person's willingness to continue these patterns, even though they know they're self-destructive. Child abuse, an abusive man in his higher brain knows he doesn't want to beat up his son, but he can't help it. When his son doesn't do what he says, he just kind of loses it.
Yeah.
He descends into the copy process of identifying with his father. And in so doing, he's providing testimony, to use the local language, to his father's ways of being, to his father's definition of how things ought to be. So again, nature programmed all that simply because it's the way we learn to adapt to threat and safety. And we don't forget it. The lower brain is not to be forgotten. So the person will say, okay, I see all this. I get it. I'm just like my father, and I don't want to beat my son. So how do I stop? That's what IRT is all about. And the first thing to say is it isn't easy.
Yeah.
And it isn't easy because you're not supposed to forget those ways.
Yeah.
But there are steps.
So you're going to tell me about the stages.
Yes. But what do I do about it question. I'm just finishing a book I've been working on for 11 years, and all kinds of people have seen copies of it. One time I got this email from somebody in Greece who thought my natural biology was fantastic. And he turns out to have been a physician. And I said, well, I'm coming to Greece on a vacation. So we got together, and it was interesting. But anyway, that was, 6 or 7 years ago. My natural biology had made it to Greece, but it still hasn't made it to USA, except here and there with people who kind of like it. But, okay, so gosh, I've free associated myself right off of your question.
No, it's great. You're telling me about the stages.
Okay, so how do you change? It's a process, and in this book, this everlasting 11-year-old draft, I go into that in considerable detail, and it's all about the overview. Is you first have to collaborate. You have to agree on the therapy goal. And when I do demonstrations in workshops of stuck cases, that's always the problem. The patient and therapist don't have the same goal. The therapist wants the patient to stop beating his child. I'll just stick with this one example and keep things simple. And the patient says he wants to. His wife's going to lead him if he doesn't. But deep inside, he's trapped into wanting to do what his father said and have his father's love. It's his gift of love to his father. He's still, the child in us is still attached and wants to do what we're supposed to. Nature says do what they did. That's the way to survive. So the first thing is to recognize that. I call it getting a case formulation. The IRT case formulation is kind of elaborate. Okay. You agree to work toward the therapy goal, and then the next thing is to learn about your patterns. And none of these stages is discrete because there's plenty of back and forth, as there always is among stages. So you have to know a little bit about your patterns to want to change them. So you learn about the copy process. You learn about the gift of love. The third stage is to begin to block problem patterns. And if we're working with suicide, we have to jump there rather early. And sometimes I jump dramatically into the case formulation to get an immediate control if the patient is in a dangerous place. I have some examples of that, but not time here for now. So, but you begin first to stop the problem patterns once you know what your patterns are. The fourth stage is where you begin what I call reconstruction. Now, that's moving from common therapies, which often seek to manage symptoms.
Palliative symptom reduction, yeah.
Yes, symptom reduction. And, so you have to do that if your definition of normal is not normal, right? I mean, if you're going to come WNL within normal limits, that means that you're going to be like other people who could mean quite a bit of craziness depending on where you are, but the not normal definition is not a positive definition of therapy goal. So it's natural that those therapies that are based on that as the outcome measure will be content with symptom management.
Yeah.
But a lot of people expect of psychotherapy that it does more than that, more than teach people to contain themselves, which is, by the way, a good thing. You certainly want to do it. But it's the transform the self so that you are a different person.
Mm-hmm.
So you have no longer are trapped in those old copy processes. So you wouldn't even dream of striking your child.
Maybe we can make a connection here to one thing also you've written about the two domains of self-discovery and self-management.
Yes.
Can you...
Yes. That's in this model. There's the 5 steps, which are that I'll just quickly fill those out and answer this right away. The 4th step is engage the will to change. That's what the new book is about. And I was starting to launch into the how do we change.
Mm-hmm.
But let's skip that at the moment and say we are going to change, really change those primitive receptors. Some of the modern behavioral therapies actually are pretty good at that point when you start to really want to reprogram yourself, really want to. And it doesn't mean betraying dad and losing all of your attachment.
Mm-hmm.
So then there's the 5th stage is to learn new patterns. Okay, so the affect management comes in at that 4th stage, and there are two categories of intervention.
Mm-hmm.
One is the management and all the modern behavioral technique, and the other side is I call it the developmental, which means going back into the past and talking about these copy processes and the gifts of love, and realizing, the fight that you had with your wife after you got home from a wonderful vacation really was testimony to your mother. You love her best after all. People don't like to hear this. They get very upset, but they agree. It's sitting there, and that is what happened. It just felt anxious when it had gone so well with his wife, especially because there was a letter waiting for Mom when he got home. And he's, 48 years old. But the reconstruction has the person go back into the past part and differentiate from the internalized representation of Mom
The internal working model in a way.
Yeah, that's right. I definitely use Bowlby's concept of internalized representations. I've used different names trying to get away from that because it's such a sin to use psychoanalysis. But I'm just out there now. It's great. I mean, obviously I disagree with the basic primitive energy model, but the basic idea of it's fabulous. And it's an important part of reconstruction. And the modern behaviorism is very, very good too. Once you have made that differentiation from the internalized representations, and you're free to become a secure self, as Bowlby would say. And I even can define normal. I'm perfectly brazen about this. I know what normal is.
What is normal?
Normal is what Bowlby called secure base, and by internalized secure base and secure base behaviors. And SASB describes that, coding his secure base category by SASB dimensions, as basically friendly and able to be enmeshed to moderate degrees. Like, you're protective of others as a therapist. You're not afraid of control when it helps them, but not control. So moderately enmeshed and moderately differentiated. You're not a loner and isolated. So baseline of friendliness, moderately enmeshed, moderately differentiated, and able to go anywhere in the interpersonal space in the right context. I was first aware of that when I was the mother of infants. I think if anyone had threatened them, I would try to kill them if I didn't have any other options. Try to escape first. But you have to go anywhere under the right circumstances.
It's interesting you're talking about that, and immediately I was brought to the idea of good enough mother for some reason. So there, clearly it evoked that image for me also. Yeah.
Yes. Oh, well, good. Our primitive brains are talking.
Yeah. But
no, there's not. I'm sorry. Go ahead.
Yeah. No, actually, I have a question about what you're saying about the willingness to change in a way. Yes. There's been a lot of talk in recent years about memory reconsolidation, and this idea that, what's the difference between talking about a thing and that thing actually making a difference? Is effective arousal here important? In what way is it important? Have you given? Of course, you've given thought to this, so I'll be very curious to think, because I'm very interested, for instance, in the work of people like Les Greenberg. And I think he's done some wonderful job also in this kind of optimal arousal stuff.
I agree.
So,
I agree. And actually, his model is great. He, by the way, used to use SASB a lot for
I
his
know. Yeah.
research and coding the two-chair situation. And I think his work is just wonderful. So, yes, he integrates the relationship with the object, as the object relations analysis, psychoanalysts would say, in the two-chair technique and in the imagination too, the internalized representation. I do the same thing. It's, you know, we are the same place on palpating the elephant, pretty much. He has different language and slightly different theory, but yes, affective, more than arousal and getting it out, but I call it integration.
Elaboration, yeah.
Integration with behavior. See, I speak of, I call them the ABC ones, affect, behavior, and primitive cognitions. And the correct sequence is C1 first,
Yeah.
Primitive apprehension of danger. Uh-oh, I'm not behaving, I'm not complying now, I'm getting off the ranch, I'm in danger. And that brings anxiety, and anxiety mobilizes me to change and figure out a way to not do the wrong thing anymore. So the little ABC1 units, I always think of them together. So in a role play, a two-chair, I'm going to be doing affect and behavior. What would you like to do now? And perception of danger or safety. So yeah, the affect work really is where the symptoms are. That is to say, it's very important. Marcia Linehan has done fabulous things here too. Very, very important, helpful work. I carry the DBT app on my iPhone, and I assign it for homework for patients to use when they get to this reconstructive stage, or when they're in crisis and they really need a quick way of getting control of themselves.
Yeah.
So, yes, affect management is very, very important in any effective treatment. And I was starting to say the reason is that psychiatric symptoms are based in the sympathetic and parasympathetic parts of the autonomic nervous system, most of them. Like anger and anxiety and depression have evolved to help us deal with threat. And so if a person has not learned adaptive ways of perceiving threat or of addressing it, they have a symptom. That's all. That's it. So the cure, the reconstructive cure, is to re-cue those symptoms, like anger. Back to our abusive dad. He'll no longer be frightened that his dad will abandon him if he doesn't beat up his kid too, and say, "It's okay, Dad. I love you. We're birds of a feather." By his behavior, if he can stand not feeling safe by copying Dad, then he can reconstruct and enjoy his son. But he's going to be terrified. And he's also, if he really succeeds at it, he's going to be despairing because he's lost his connection to the dad in his head. I speak of family in the head as internalized representations. That's my latest version. I keep making different names. But it is family therapy in the head. And I will bring in families too to help, always to help the identified patient focus there. The idea of systems itself is overwhelming to me. Too much is going on. It's like an affective storm. I wouldn't know where to begin. But I can focus on an identified patient very helpfully. And so, yes, Les and Marcia are my favorites for affect management.
I was thinking when you were talking also, there's the British psychoanalyst Adam Phillips. He once wrote that just as there are phantom limbs, there can be phantom people. Like we act as if they are still there in a way.
Oh, listen, when I love being primitive, and sometimes I get a little off the ranch with that, but well-functioning people, if I'm connecting with them and I ask them, who's talking now? They hear it. They hear their dad. The executive who's anxious, he hears his mom criticize him. And they fear they'll be called psychotic. a schizophrenic I worked with once helped me with that. I said, well, your voice, tell me about him, because he was a friend and an enemy. I said, how did he become a voice? And he said, well, when I made him a voice, I didn't have him all the time. If it was just me, I couldn't escape myself. I thought that was wonderful.
That's great.
Yes, I've learned a lot from patients.
Uh-huh.
And I've often said in family therapy when I've done it, the identified patient is the only one who's telling the truth, the primitive truth.
By the way, and with all this new technology, I'm also curious to think about how you think would be useful the possibilities of video recording the sessions. It's been happening a little bit more in recent decades, so what do you think are the possibilities for that, in terms of research and of training?
Well, I do it. I'm probably one of the more public therapists. There's tons, hundreds of videos in the hospital library of me doing these consultative interviews. And people were more public with their work.
Yeah.
And were more explicit about what they're doing. I hardly approve of it, but I understand it is difficult. And I've spent the last 2 weeks going through the institutional requirements for this, which are good. They're needed. The patient has to give an informed consent and has to be truly informed and has to be able to control the tape. So my tapes can be destroyed anytime by the people that are on them. And they know exactly how to do it. And they can't destroy anything that's been done up to then, but they have all kinds of control, all kinds of information, and there's protected viewing of them. So I won't, for example, show them on a webinar. There's not enough control.
Yeah.
I'll show them to an audience, but I insist that the sponsors ensure that everyone is a licensed health professional. That's what I promised.
Yeah.
For teaching within an institution, it's much easier. So I think that it would be quite easy in a psychology program to have supervision with video. Yeah. And we developed a special form where the student gives permission to do that. And they understand that kind of feedback, or the ones that are mature enough anyway, understand that kind of feed. It's like playing music, Who cares if you just play all by yourself, right? And so it's I think we need much more of it. It'd be better teaching, more accountability, and students would be better prepared when they sent out to practice.
For sure.
They get out and meet reality, and they need help.
Yeah, for sure. All the help we can get.
Yeah. Well, I think in Europe you get a better exposure of different approaches.
I would argue that, to be honest, at least in Portugal. Yeah. I think that there still is a big community of colleges divided in different models. So it depends a lot. And unfortunately, it's still sometimes like this.
I think having a theory, a natural biological theory, helps you choose among models.
Yeah.
That's what I claim IRT does.
I think that's pretty rare. It would be wonderful, but still quite rare. But, I was thinking I'd like to play we're just finishing off, but still, I'd like to play a little game with you, if you don't mind.
Okay.
I'd like to name some names that I think were in some way influential in your career. And if you could just briefly tell us a little main lesson or idea you got from them.
Okay, I hope I remember them.
I don't think it would be hard, I think. So The first one I would like to ask you is your former supervisor and one of my personal heroes, Carl Rogers.
Yes. Well, I already referred to him. He's, what I remember most was his, you want to know the truth? Mm-hmm. What I remember most, my primitive brain, is that he liked what I did. Uh-huh. That's what comes to my primitive. You felt
valued by him. Yeah.
Yes. Uh-huh. Yes, but I felt it was genuine.
Yeah.
He had ways of showing that. So I experienced his empathy and his affirmation. That's the first thing that comes to mind.
That's great. And Carl Whitaker?
Oh. I was fascinated by him
Yeah.
because I could see the genius in what he did, but I also could see, I hope he'll forgive me wherever he is now, the cowboy in him. And I was determined to figure out what he did that was so constructive and what he did that didn't work out so well. And that was in the 60s, I would say, when sexism, which definitely has not gone away, but when it was really rampant.
Yeah.
And so I thought he was unduly hard on mothers. That's a basic issue.
Okay.
But that was the theory, and that's what people did. But an example, a quick association of his genius, there was a analyst in our department that I was working in at the time that killed himself, and his wife did too, and it was a big dramatic effect in the newspapers. And this woman had been a patient of his, of not Carl's, but of the deceased analyst, yes. And Carl and I were called in to help this family.
Yes.
And this woman was in an out-of-control manic state, and we just couldn't do anything. And Carl, who was a rather large man, sat on her. He sat on her, and he said, "Be quiet and listen and talk to us." And he sat the whole session, and she participated. She did.
So
he would be in court now, of course.
Exactly. So I get the feeling that some of these more family systems guys were quite intuitive.
Yes, I saw them, and yes, I have quite a bit of that in me. And now and then I try it out, and sometimes it works, but it's not a good idea.
It's cowboy. So another one I'll just have to ask, which is 𝗔𝗋𝗃𝗅.
Well, yes, I really liked him. And he was at the primate lab, and it was the collaboration between him and Harlow was wonderful. And I have said, he did ask me to come work with him in Tavistock, and I've made the very bad joke that I made the wrong decision. I decided to stay married at the time. So I mean, his work is central to what I'm doing now.
Yeah.
And his person is with me. He was a kind man and a smart man.
And Harlow?
Harlow. I liked Harlow. Harlow played hardball, and he delighted in challenging students and giving them a hard time. And I was just sassy and brazen enough to like to play fight with him, and he liked it. So we had banter. And my biggest joke on him was one time when he was often gone on speeches, was unusual for academics, but he'd be gone. The private lab did well. It had good personnel, and we all proceeded nicely. But I drew a picture of him. I put his head, a very large version of his head, on the body of a baby monkey clinging onto the mother surrogate. And I drew it big, and I put it on a rack and put it in his office, so when he first came in the office, he would see it. And Fred Sponholz, who was the lab photographer, said to me, "You cannot do that." And I said, "Yes, I can, because this is the relationship we had." And Harry never said a word to me about that picture, but Fred told me that Harry had him take a picture of my picture, and I have it to this day. And he said that Harry sent it out as his Christmas card that year, saying this was his baby picture.
That's so great.
So he was fun if you stood up to him, but he would cream you if you didn't.
So you needed to be tough also.
Yes. Yeah. Nowadays, of course, I'd be defrocked for doing anything like that.
It's become more rigid in a way.
Oh, very hostile. Very hostile.
How about Harry Stack Sullivan?
I never met him in person, but I did certainly read and followed his interpersonal perspective a lot. I liked his character analysis. I think that's what people mean when they talk about personality now. And I actually am playing with a huge database this very week about, does personality disorder diminish anxiety and depression? because, you know, that's the old character analysis idea of a person is a pain in the neck in behavior and isn't running around with internalizing symptoms.
Yeah, yeah. Uh-huh.
And I think I can kind of support that. I'm derailed from finishing the book. I get a nice data pile, and that's just terrible. I sort of sneak off like another addict.
So, in your ever never-ending draft, when do you think are you planning to put that out?
Well, I'm coming to Europe for 23 days of workshop in October, and I had wanted to get it to the editors in its final version before leaving. I think now I got derailed by another editor who sat on my manuscript for a year and a half and now has to have it right away. And that's taken a couple of weeks out. I don't know if I'll make it.
Well, one last person that we already talked about also would be Leslie Greenberg.
Oh, well, Les and I would meet at, I would call them NIH prima donna meetings. I say add prima donnas and stir. That was the NIH's idea of integration. But I was privileged enough while I was holding a grant to come and meet a lot of wonderful people, and Les was one of them. And we just got along and thought similarly. And he, as I say, he liked SASB. I liked that he was a physicist, a rigorous thinker.
Yeah.
And just made a lot of sense, and also a very kind person.
So I always finish off with a question that I've asked all of our colleagues, and now I have the pleasure of asking you also. I'd be curious to ask you, what advice would you wish to have received when you were starting out as a psychotherapist?
I'm not a very dependent person, but I sure liked the modeling. I liked therapy was taught by imitation, so I felt it was a gift for the therapists then to show themselves, and they did. They would treat a patient behind a one-way mirror, and I could see them work, and that was a gift, and that was their primitive brain advice to me.
So modeling, looking at, experiencing with
the real deal, and talking about it, and being vulnerable to questions.
Yeah.
And being responsive, and being curious. I would like therapists to be curious and thoughtful in a basic theoretical way. I think I got all the advice I needed, which was, I've talked about it, affirmation and inspiration.
Lorna, thank you so much for the opportunity of chatting.
Well, thank you for a wonderful interview. And I'm 82 now, but I hope I last long enough to see what happens to you, because it's going to be a good thing. And don't edit that out, please.
That's so nice. Thank you so much.
I'm required by the University of Utah Conflict of Interest Committee to disclose that I have an author's interest in the SASB model, which I gave to the university, but if it's ever sold to a testing company, I would get a proportion of SASB. And I also give workshops for a fee, and I also have a private practice fee. So that is for your information and consideration when you think about what I say.